Well, good afternoon again, everyone, and thank you so much for taking time out of your day to attend our webinar regarding the Community Health Needs Assessment Best Practices. 2018 starts the third round of CHNAs, as I call them. So I'm sure everyone is going to be gearing up to once again do their 3-year evaluation and needs assessment report for your organization. So we will be talking about some best practices. We're going to be talking about the IRS rulings that happened at the end of 2014 and what you should be putting into your needs assessments so that you don't miss anything, because the IRS is starting to audit hospitals. In fact, one of our clients, the IRS did come knocking last summer because they could not find one of the hospitals in their system, their implementation strategy, and wanted proof that they did indeed have one. So the IRS is out there with about 30 or so auditors that they've hired and going out and starting to really review the needs assessments and implementation strategies. So hopefully through this information, we will make sure that you are compliant for your next go-around. So most of you that are on the call know about Strategy Solutions. You've been in our webinars before, but we not only work with the healthcare industry with needs assessments, implementation strategies, evaluations of your strategies, community benefit inventory, logic model training, but we also work a lot with nonprofits and helping them with strategic planning, enterprise transformation. And Debbie Thompson, who is our president, actually worked in a healthcare organization, actually did their first needs assessment back in the early 90s, and from there started Strategy Solutions. So we've been helping out and making communities healthier ever since. One of the things that we really like to do is not only help organizations with their needs assessments, but to also teach them and coach them so that they feel comfortable doing it themselves the next go around, or using us for more of a sounding board type thing. And this graphic just shows a lot of the questions that, you know, we like to have people ask in order to plan and evaluate their needs assessment and the process for doing that. So the objectives for this webinar is hopefully by the end of the session, you will be able to understand the spirit and the letter of the law regarding your CHNA and implementation strategy planning process, to identify tools and methods to conduct a successful CHNA, and to understand the benefits of collaborating when you are completing a CHNA. Especially in some states like New York and Ohio, it's mandatory that you work with your local or county public health department to do your needs assessment. And in Ohio and New York, the state Department of Health has actually said, here are the top 10 areas of concern, and you have to pick 2 or you have to pick 4 and make sure that you address those in your needs assessment, as opposed to maybe working on homelessness to cut down on your readmission rates. Maybe that's not on the list. So the 2 that you would have to be picking with and working in conjunction with the health department might be different from a state that doesn't have those rules and regulations. So just something to think about and check on to make sure that you're up to date on what the state is also requiring where you are located. So we've shown this slide on other webinars if you have attended. But the IRS has, the letter of the law, things that you have to do. You have to conduct it every 3 years. You have to identify chronic disease conditions in your community and other community health needs in your area. You have to include input from public health, from community stakeholders, and try and really reaching the underserved, low-income, minority populations. And we'll go into a little more, but that's reaching them through surveys, through focus groups, through we like to call one-on-one focus groups, where you might go and hang out at a food pantry for the day and ask everyone who comes in the same series of questions to kind of, understand what their needs are. and also to evaluate your outcomes and impact annually with your 990 submission that you'd be working with your tax department or your finance department in order to give them the information that they are looking for. But also the reason why you're doing the assessments and why the IRS has made this a mandate that every 3 years you have to do it is so that it's just you are taking a step back and actually seeing what is happening in your community and how can you make a difference, in your community, whether you're concentrating on prevention and really maybe offering a lot more screenings, or seeing that, one of our clients, their mammogram rate for the last CHNA was extremely low. It was in the mid-60s, and the breast cancer rate went up. So even though they do not offer whatsoever any type of women's health at their hospital, they actually took it upon themselves to notice that even though they don't have women's health, the women were coming to their facility to get their mammograms, but then going back to their PCP or their OBGYN for the results and follow-up. So they instituted a postcard reminder where everyone that was identified as coming into their hospital just for that test, they would get a reminder card. Not necessarily a patient of theirs or in their system through, one of their PCPs, but just to remind them to try and get the word out that it really is important to get mammograms. So, concentrating on prevention or concentrating more on stopping pre-diabetes as opposed to concentrating on diabetes after a patient has it. Addressing needs of the vulnerable population, working with area organizations to reduce homelessness in their area so that the readmission rates are lower, because some of our clients found that you had the homeless population coming to the hospital because they needed a Band-Aid, or they wanted to get warm, or they just wanted to talk to somebody. And actually working with organizations to, up in Vermont, we heard that hospital and homeless agency and the housing authority got together, and I believe the hospital put in like $40,000, bought this seedy motel, they refurbished it, and when the homeless people that were identified were discharged, they had a place to go for 2 weeks that had 24-hour care, had a caseworker, had a nurse practitioner, and within the first year, the hospital saw $700,000 savings because of the lowering of readmission rates on those people. So, in a nutshell, that's kind of why you're supposed to be doing the needs assessment, is to, identify what is going on in your community, work on, specific needs that are going to help the community, and of course, hopefully be a community benefit for the hospital, but really going out and tackling more than, just the major chronic diseases that would be coming into the hospital. And this is, just talking real quick about how the American Hospital Association has really been talking about over time about going from the first curve of a volume-based business model for healthcare to more of a value-based business model for the second curve. So when we talk about the CHNA, we really encourage aligning your CHNA with population health and the value-based payment model. So you have your CHNA as your hub that you do every 3 years. But from there, what is your end game? Well, you want your community to have better health. You want the patient to be engaged in their health care themselves rather than just not coming in, but really encourage them to get more on the preventative side and stop things maybe before they're happening as opposed to just being reactive, and also offering quality services to lower readmission rates. So the final IRS requirements that came out on December 29th of 2014, there were some what we call major points that had changed from what was the suggested regulations and requirements that came out in 2011 for the 2013 first go-around of the CHNAs. And so they really encourage collaboration on a CHNA. It's not mandated, but it is highly encourage that you collaborate. So for instance, you might collaborate with other hospitals in your area, like one of our clients who was on the webinar with us. Hi, Lauren. There's actually 6 hospitals and the public health department that came together to do their needs assessment and to work on certain initiatives collaboratively, even though they're getting their information, in different ways for their hospital community, but working together to try and, lower the numbers on obesity and getting more information, education out for nutrition and physical activity. Our client up in Alaska actually partnered with all of the nonprofit agencies in the town. So working with Early Connections and working with the tribal clinics and working with, I can't think of the other 2 at the moment, but they actually gave information that became part of the needs assessment, and they were then using that for their assessment that they had to do and were required to submit to keep their nonprofit status as well. But the thing to remember is that even if you do a collaborative needs assessment, every hospital has to have their own implementation strategy. You could have, the same things, working on the same goals or working on the same chronic disease, but it has to be specific to that hospital. One of our other clients actually would do a write-up and bring in what is happening in that community, but at the end, their spreadsheet actually had all of their hospital locations and then just X marks on which hospital location was working on what action, activity, or goal. The CHNA must take into account input from persons who represent the broad interests of the community served by the hospital facility. Again, I kind of touched on that on an earlier slide. It's really making sure that you identify all of the underserved populations, low-income populations, so that you can find out what their needs are. So, ideally, it would be going out and doing focus groups or meeting one-on-one with groups, like I mentioned, with going to a food pantry for a day. But if, it's impossible to get that, or, you're under a time constraint because, oh my goodness, we had someone who was in charge of our needs assessment, but they left and the ball got dropped and we have a month to do it, at least getting stakeholders that represent those people who can speak on their behalf to show that you really did a concerted effort trying to get to the bottom of what the needs are for those underserved and low-income populations, as well as minority populations. And sometimes, sometimes it's hard, and sometimes even though you would love to get that information, you just can't find anybody that is willing to talk, and then you speak to that in your assessment just to let them know that you did try, but unfortunately it just, for whatever reason, couldn't happen. In assessing community health needs, hospitals must also identify resources available to address those needs. And what this is speaking to is in the 2013 and 2014 go-around, it was required that you had to list out all the community resources that were available to the community. So that could be your hotlines, that could be your support groups that are in the community, anything that someone could use to better themselves. And a good place that we usually get our information from would be like the United Way usually has a really good resource directory of those community resources. But no one listed the hospital resources. So the IRS said, oh, wait a minute, the hospital is a resource. So moving forward from 2014, end of 2014 on, you must also list out all of your hospital resources. All of the hospital support groups, all of the outpatient clinics, all of the mental health departments that you might have. Anything that the hospital is offering to the public should be listed as a resource. The implementation strategy must describe how the hospital plans to address each significant need or why the hospital does not intend to address the need, and identify resources the hospital plans to commit to address the health need, along with any planned collaboration and the anticipated impact of these actions. And you must furnish that annually on your 990. So what we suggest with our clients is that you meet every quarter. You want to get people used to reporting to you, so it's just not the Maureen show or it's just not the Lauren show, that every single department and person that's listed on that implementation strategy knows that they are required to get information to you. And by meeting quarterly, it gets them used to reporting that information so that at year end, you're not going, oh my goodness, what did we do? You have all that information you can put in a report to give to your finance department to file with your 990. Also, the new changes were extra time is now available to complete your implementation strategy development and posting. So in prior years, you not only had to do your needs assessment, but you also had to do your implementation strategy, and it had to be in one report. The IRS said, well, wait a minute, a lot of times the hospitals are still trying to process all that information from the needs assessment. So we're going to give you 4.5 months to complete that implementation strategy, get it approved by your board, and get it published up on your website so that the public knows that it's there and can access it, as well as the IRS checking up on you. And a lot of times, we had a client where they wanted it all part of the needs assessment, and that's fine too. It's just the IRS is giving you an extra 4.5 months to get that done. And the CHNA report must also include an evaluation of your last most CHNA. So you have to actually have a chapter in your needs assessment now that actually is evaluating what happened with that implementation strategy over the last 3 years with your last CHNA, and you have to report on that. So what do you need to have in your needs assessment? Well, the IRS is saying you need to have a definition of the community served by the hospital. You need to look at and report on the demographics of your community. You need to have and list existing healthcare facilities and resources within the community that are available to respond to the health needs of the community, as well as any community resource. You have to list how your data was obtained, almost like a bibliography. Where did you get all of the data? And it's also nice to source right underneath your table, your data table or your data chart, where you actually got that information. You also need to talk about and list all the significant health needs of the community that you found through the process of your needs assessment, whether it's stakeholder interviews, whether it's focus groups, whether it's a community survey. How did you get the information, and what came out of it as your significant health needs? You also have to report on your primary and chronic disease needs and other health issues of uninsured persons, low-income persons, and minority groups. You have to speak to what you found from talking to those groups. You have to report on the process for identifying and prioritizing community health needs and services to meet their community health needs. So we like to suggest after you, what you want to do is create a steering committee. So it's just not on your shoulders, that you have a group of people, whether you have great contacts on the outside because you know obesity is a big problem. So we want to get maybe the person from the Y to be on your steering committee for the needs assessment. You want to get clinicians and program managers from your hospital organization. And so you want to have a kickoff meeting to explain everything to them. This is why we're doing this needs assessment. And then bringing them back after you have all of the data to talk about what you found. And then you want to have a meeting where you're actually prioritizing all of that information. And we always prioritize 4 ways. We have, what is the impact to the community on this need? What is the magnitude of it? Do we have the capacity to handle working on this need, or is it for somebody other than the hospital? Because the hospital isn't set up maybe to do women's health, and women's health was a huge issue. But there's different ways to prioritize, but that is something that you need to show that you then took a step back and had everybody prioritize what they feel are the significant needs for the hospital. You have to report on the process for consulting with persons representing the community interests. You have to report on the impact of any actions taken to address the significant health needs. And you have to report and indicate the tax year that the hospital actually conducted a needs assessment. That is a check mark on the Form 990. In conducting its most recent CHNA, you have to make sure, did the hospital facility take into account input from persons who represent? And these next ones are actually taken right from the 990, questions that you would need to answer. Was the hospital facility CHNA conducted with one or more other hospital facilities, showing collaboration? Did the hospital facility make its CHNA widely available to the public? You need to make sure that you have your latest, and actually any needs assessment that you've done needs to be put up onto your hospital website. We always suggest having it one click from the home page so it's easy to find and people don't have to search for it. Is it on anyone else's website? Did you collaborate with, say, United Way so that CHNA is also on their website, including that URL? Do you have a paper copy of that needs assessment that is being held by the CEO's executive assistant or in the population health department, but do you have a paper copy available, and does everybody in the hospital know that that person is holding it? So if I come in off the street and say, I'd like to see your needs assessment, someone can say, oh, well, let me get so-and-so. They have the copy that you can look at. But those are ways to make it widely available. Did the hospital facility adopt an implementation strategy to address the significant needs after the CHNA was conducted? Is the hospital facility's most recently adopted implementation strategy posted on the website? If yes, it is. If not, then you have to attach it to your 990 and explain why it's not up on your website. If the hospital facility addressed needs identified in the most recently conducted CHNA, you have to indicate how by checking all that apply. Did you adopt an implementation strategy? Was there an execution of the implementation strategy? Did you have participation in the development of the community-wide community benefit plan? Did you include a community benefit section in your plan? Do you adopt a budget? Now here, this is also something that's a little new, is that the IRS is requiring you to put a budget to your implementation strategy. And you might be thinking, oh my gosh, that's going to be very time consuming. Basically, the IRS is doing that because in 2013, people were saying, well, we have a need, we have women's health issues, we're going to build a wing of our hospital. Well, nobody budgeted for that, but they just kind of came out with all of these ideas and published them. So the IRS said, you know what, we want a budget attached to your implementation strategy so we know that you've thought about what you're doing and actually put a dollar amount to it. Do we suggest putting a dollar amount to every single line item? No, that would drive me insane. I'm sure it would drive you insane. But either assigning a 3-year dollar amount to each goal or just an overall dollar amount to your entire implementation strategy is acceptable. But you need to show on your 990 that you have funds that were budgeted and approved to meet and carry out everything that's on that implementation strategy. Did the hospital facility address all the needs identified in its most recently conducted CHNA? If no, why weren't they? So every year when you do your evaluation, you'll go through your strategy and say, yep, goal 1, objective A, B, C, and E, we began the programs, they're going great, here's some impact and outcome measurements on that. But for objective D, we were hoping that we got the grant for a mobile clinic. The grant didn't come through. We don't have that budgeted. So by just saying, goal D or objective D, we wrote a grant for this. We did not receive the grant, nor did we budget the funds for this, so we are no longer pursuing a mobile clinic. And that's all you have to say. But showing and acknowledging that there are some things that didn't happen, or maybe your implementation strategy, it didn't happen because it's not happening until year 3. But actually just addressing that, and then each year that would just be on there until you have your new needs assessment. But just not talking about every single objective under every goal is not what the IRS wants. They want an explanation for everything. And then also talking about financial assistance policy, and that's more for the finance department to make sure that they address that question. So what approach could or should you use in your community health assessment process? There's a lot of people that they only use the needs assessment because it's something that they're required to do. And then it gets put on a shelf for 3 years and they don't really do anything, or they only do the minimum. And then there are some people that, they really take the needs assessment to heart and embrace what it truly is for, is to trying to help the community and really having collaboration with a coalition of agencies in their community. So hospital health system driven is option 1. It might include a combination of all kinds of data elements. You have a community collaborator would be option 2. And then you also have a capacity building model where any of the other options, including teaching, internal staff, and our volunteers to collect and analyze data, would be the optimum of what you're doing with your needs assessment. So questions to get started. Which players should be at the table? As I mentioned, when you're starting this out, you want to have people that are going to help you, who are part of, all hospitals know what your significant needs are. There might be, maybe you thought diabetes was a huge issue, but when you went out in the community and asked, that wasn't. It was getting nutritional food into the area because the area is a food desert. So who could I have to be on my steering committee to work on this with me that would be able to address that need? So is your hospital a single hospital or a multi-hospital effort? Is this a community-wide effort or a health system effort? What is each hospital's vision of their community or constituency for which they intend to impact health? You definitely want to make sure that you have or invite your public health person from your area. That is a person that really needs to be on your steering committee. Your steering committee should also include clinicians or program managers of areas that you're going to be working on. Should you invite someone from the United Way? Should you invite someone from faith-based? There's a lot of movement now where they are doing health coaching through the faith-based organizations. Retired nurses in churches are getting organizations together and actually going out and meeting with people in the community to help them stay out of the hospital, with making sure their home is safe, to driving them to appointments. That faith-based nursing coalition is really picking up steam and helping, especially rural communities, keep those readmission rates low. How will everything be funded? Is it going to be the hospital that's going to fund everything? Hope not. Are they going to get participation and assistance from public health and other community entities? We had a client who called up because the person that was supposed to do the needs assessment wasn't there, and no one reminded them. So we helped them with their needs assessment, and they were a hospital that was hopefully going to be merged into a larger system. They had no money whatsoever. And they found out that there was a lady in town that was doing a push for Healthy X County and Healthy X County, because they had a couple counties, and actually had a program where there was a walking program, and there was a nutrition program, and there was cooking demonstrations that they had funding and were doing. So the hospital partnered with them and said, will you take over keeping track of all the numbers since you already have this community program going? It didn't cost the hospital anything, but then at the end of each year, they got those numbers to report on because they partnered with someone that was already doing it. What is the geography of the study? Is it the individual player service territories, or is it something that's combined? A reasonable geographic footprint of your community or region, or is it something else? What is your geography of the study for your CHNA? What types of data could or should you use in your community health assessment process? Well, you need some secondary data, and that can range from, demographics, pulled down from, the U.S. Census Bureau, birth and death characteristics, even though Pennsylvania is slow on the uptake as far as Department of Health and, really rallying, they have one of the best databases for information. So going and looking up and getting that information from your public health department's website is a place to go. Disease incidence and prevalence, pulling down BRFSS information, health status and health behavior, healthcare utilization. We always ask for that from each of the hospitals. What is your hospital utilization information at discharge, to kind of see what your trends are. Social and community issues. What are the crime rates? What are the homelessness population? Family or gang violence, quality of life. I did read China where they were not understanding what was the ask from their population health department, so contacted us and to say, hey, can you redo this? And when I was reviewing it, was kind of shocked because they had some real personal violence against women information in there that, for China should not have probably been in there. But, is there a huge child abuse population in your area that you may want to speak to, possibly working with the school districts to do an after-school program? One of our clients works with the Y and offers an after-school program for children. Getting information from the school and student population, economic data from your workforce development agencies, environmental data, what are your smog days? Because that has a huge impact on health if you are in an area where there's, a lot of smog days and air quality days. Well-being related data. So, we get a lot of our data. We'll look at the county and say, okay, let's contact the United Way, see what reports they can give us. And, why reinvent the wheel if, the Pittsburgh Department of Health just put out their needs assessment last year. They're going to have, data hopefully through 2015 that, you could pull from or we could pull from. So, actually contacting those nonprofit and agencies in your area that might have reports and assessments that you could use in making your community health needs assessment. And are there any other community needs assessments, like I just mentioned, in the community that you could get information from? Regarding primary data, surveys, interviews, focus groups. And we'll go into each one of those in depth. But basically data collection considerations is the verbal and written literacy levels of the respondents. You really, really have to take that into account and almost do everything at a third grade level if you're doing any type of survey or question. Because they're not going to know how to respond, and we found that out up in Alaska and quickly changed the survey language to make it more of a third grade level. What is the primary language of the respondents? Do you have a huge Korean population or a huge Hispanic population? Do you need to get that survey translated, or do you need to get focus group or interview questions translated so that they understand what the ask is? The culture norms of the target population, the expertise needed to analyze the data are things that you need to think of. Comparative data, trends over time in a single population or community, comparing what happened with your last needs assessment to the data that you just pulled down for this year's needs assessment. What are the trends? And then talking about and focusing on those that are a negative trend. Comparisons of your local data to county, state, or even national data for the same time period, and comparisons to national standards or benchmarks. Longitudinal data, do you have the ability of following patients from, they come to a women's health fair and you have schedulers there and they schedule a person for a mammogram. Do you have any processes or protocols set up so you can follow that person? Yes, they handed this card in, and I know it was from the health fair, and they got their mammogram. Is someone following up to see if it was a clean mammogram or did they have to get a biopsy? If they got a biopsy, was breast cancer caught, and at what stage was that caught? And then following them through any type of treatment. Do you need to institute a distress tool and follow them as far as their stress level going through any type of treatment? Is ways to also get data on specific people showing that, yes, your protocols are working, or, geez, we really need to follow up more in this area because we're not capturing that data. Epidemiological data, it's the study factors affecting the health and illness of populations, serves as a foundation and logic of interventions made in the interest of public health, preventative medicine, is other data that you can collect. Questions to consider: what data do we need? What is your overall goal of the assessment? Is it just for compliance, or do you actually want to do something in the community with that assessment? What are your target populations that you know? You know your community. You know that we have a heavy Native American population, or we have a heavy Amish population. How can we get in to talk to those populations that is usually a barrier to try and get health care? And what are your geographic areas? One of our clients was in between a mountain, so there really was a mountain mentality. I'm not going to cross a mountain that takes 15 minutes to get health care. I'm staying in the valley. What is the range of health and social issues to be addressed? What specific types of data are needed to learn what you want to know, and in what ways will you get that data? Will the data be used to set priorities and plan programs? How will the assessment results be communicated, and who are you going to communicate them to? What specific information will help you learn what you want to know and achieve for the assessment purpose? Does the desired information already exist in some form that you need, or do you have to extract it from somewhere? Do you have to gather it? Will new data be needed to answer some of the questions or to address some of the gaps? We had a client where they went to do the prioritization, and through that prioritization process found out that there were some holes where they really did not have any information on this minority group, so stopped the entire needs assessment process in order to get that data from that minority group to put into the needs assessment and then reprioritize. Who's responsible for collecting the data and analyzing the data? Is it just you because you're a small hospital and it's just the Kathy show, or are you going to have a team of people that are going to gather that data? Other questions: are there reasons to think that any conditions found in a previous local assessment have changed substantially? For instance, when I talked about how mammograms really declined from 2013 through 2015, shockingly so. Well, why? They didn't have the answers to that question because they didn't have any women's health. So they're taking steps to find out and get some of that information for their next CHNA go around. Did the previous assessment process raise new questions that could be answered through this assessment? Are there issues that could be probed more deeply? Are there gaps? And are there important population groups that you really want to touch on? Potential data elements. Most assessments are just going to report on demographics, disease incidence, and behavioral risk factors and needs of the community. But what about having what about the physician workforce, doing a physician inventory? Is the reason why everyone is visiting the ER because you don't have enough physicians in your area, or the physicians that you have don't have office hours that are conducive to working people? Some things to think about. Culture: what is the infrastructure capacity, marketing, customer focus, research, education? What is the reputation of the hospital? External data that you can get. But again, looking more than just and reporting on more than just the demographics, disease incidents, and then the community needs. In fact, we have one co-presenter of a webinar that, huge overweight and obesity problem in their community. And the population health person really wanted to do something so ended up looking and seeing what her avenues were, asked to be part of the county planning committee, and was instrumental in getting a huge walking path established for their community and a walking program through that. So not only just staying within the hospital bounds, but saying, what can I do to make a difference? Other ways to collect primary data is telephone surveys, hiring a third party to do a BRFSS survey. If you really think that, we are so out of touch with the community, or we know that there is a huge issue with huge problems in the community because we had an influx of people moving into the area, and, using some of that money to do a phone survey to get what those health needs are. Paper internet surveys. SurveyMonkey is free, and, creating an internet survey. We do this a lot with our clients, where we actually have BRFSS questions in our internet survey, as well as ones that maybe the hospital would like to find more information about. And, blast the link, and, we encourage in newspapers and on the website and in the doctor's offices, but also depending on your community, do you need to have paper surveys at all of your PCP offices or at the food bank, and then having an intern input them into SurveyMonkey. It's a quick way to do it. A lot of times if you have a little giveaway, if you, fill out the survey, you get more survey responses, but the disadvantage is that, you may not have the bandwidth to input surveys yourself, or, you're in a rural area and, the Wi-Fi is spotty, so internet survey is not going to work. Interviews. Having stakeholder interviews is another way to collect, data. Talking to people who have the pulse of the underserved and the low income and the minority populations, especially if you can't get them, is a good way to get information, because what you really want to prove is that all of the information that you received and pulled through secondary data is going to be backed up by what you hear from the survey and from the interviews and from focus groups. And focus groups. What we always recommend to our clients is that when you start your needs assessment process is to look at your community calendar. What the heck is going on in your community that you can, as I say, quote, hijack a portion of a gathering to get information. So we actually went to a senior citizen center where they were having, it was a flu shot clinic, and they had a lunch, and we hijacked the lunch and did a focus group there to get information from the senior population. One of our clients actually went out with paper surveys for the county fair and walked around and asked questions as a one-on-one focus group at the health fair. So, you most certainly can have people come to the hospital or go out into the community and set up focus group meetings, but it's also good to see what meetings are already taking place that you could go in, and for 30 minutes to an hour be on the agenda and do a focus group. Something else that we encourage is asset mapping, is actually having and creating a map, a lot of times using a third party. We use a third party person, where you give them all the addresses of all your community resources and hospital resources in the area, and they map it so you can actually see, and everyone can see that, okay, well, here's the center hub of our county, and here's where, 99% of the services are. What can we do to get those people in those outlying areas in our county to receive services? Sad story from one of our clients. The president of the hospital spoke and, said we have a huge transportation problem. We have a very rural population, and a gentleman had a severe wound and had to come to the wound clinic every day for 12 weeks. And he had no transportation, so he elected to have his leg amputated because he did not have any transportation to go to that wound clinic every day. So doing an asset mapping to really identify where the cluster of resources are, and what you could do to reach those outlying areas to provide some type of healthcare service for them or transportation service. Criteria for selecting priorities, the community capacity to act on issues, including economic, social, cultural, political. Is it feasible to act on the priority? Community resources, what's out there that can help address the issue, and whether the issue is a root cause of another problem affecting it, or is it a key problem on its own? Convene the team and develop your strategy. As I talked about, convening a steering committee and, talking about what your strategies are. What are you going to do over the next 3 years to tackle and address the main issues that you want to? So, say out of the prioritization and looking at the data and the negative trends and the problems that you're hearing through stakeholder interviews and focus groups in the survey, it's theoretical that you might have 82 problems in your area. Well, you can't work on 82 things. That's where prioritization comes in. But then it's up to the steering committee or it's up to senior leadership to look at that list and say, you know what, we can group all these as chronic disease. Or we're already doing things, so that's a no biggie. Yeah, and, saying, okay, we're going to work on these issues for over the next 3 years. We're not going to work on these issues because the Y has programs to tackle obesity, or we have an agency in town that is working closely with the veterans, or we have a mental health conglomerate that is working on mental health, and pointing out that what is in the community that can help with that need because it's not in the hospital's wheelhouse. Implementation team, what does it do? It acts as the forum to develop and monitor tactical goals and achievement, to collaborate, to leverage resources, to measure progress. Who should you have involved in your implementation team? Population health or public health leadership for sure. Service line leaders responsible for clinical programs like diabetes or cancer or heart disease. Clinical champions that are in your system or understand what's happening. That would be a go-getter for that team. Public affairs and communication. You definitely don't want it to just be a one-person show. It would be overwhelming, and it just is not conducive to really reaching out and doing things in the community. So if you have a single-site hospital, you have your CHNA team, which will be your champions, your service line leaders, your public relations people, because usually a lot of times in a lot of hospitals, it's the marketing department that's in charge of the needs assessment. And so you want to align with programs and service lines of the hospital so that you have those people that understand the needs and what happens and how to get the measurements at the end of each year, rather than a marketing person. Finance person, you should always have a data IS person. In our last webinar that we had last month, you definitely want to make friends with that informatics person, because depending on what system you use, they might be able to look at all the nurses' notes and say, you know what, nurses' notes has a lot of great data, but it all centers around 9 things. Let's create a drop down of those 9 things that they can just click, and you would be able to get better information out from like your Epic system, for example. Or they might be able to strategize with you on how, when you're at a health fair, to give you a laptop or an iPad that works offline, that you can gather the data. When you come back to the hospital, it uploads, and then you have that information on that touch point to the community. And then as well as your CHNA coordinator. I talked a little bit about some of our clients. Healthcare Council of Lehigh Valley was a collaborative of 8 regional health entities. The key learnings that came out of it was common needs, which is why they came together for regional data and to mandate to produce a CHNA for the same area, so they didn't have to reinvent the wheel 8 times. Opportunity and challenges to find common ground that they could all commit to helping and working on, having a role of a facilitator for the regional group, and the need for transparency and being clear about each organization's agenda and why they came to the table. This is talking about having an implementation process at multiple sites, and you can read more into that. Talking about single site versus cross-cutting, where it was Lehigh Valley tactics. that they had. So what they did was they identified needs that were going to be across the system. But then for their implementation strategy, they actually said, well, for the Hazeltown location, this is what they're also going to be concentrating on because they have a particular need because of a high rate of cancer mortality. Or Lehigh Valley School that just came on board. They had a mortality equity for primary care and express care. They were short on PCPs. And also they had a huge opioid explosion coming up from Maryland and really wanting to tackle that and how it relates to mental health, as well as trying to bring up their mammogram rates because they also dipped as well. So they took approach of, everyone is going to be working on depression screening so that we all have the same depression screening throughout our system, but understanding that each of those areas where a system has a different population, and this is what you're going to work on. And that speaks to what I mentioned earlier, where the IRS is looking to make sure that the implementation strategy that is posted on your hospital, or if you're a hospital system, is particular to your hospital and your community. Evaluate outcomes and your interventions. This is big. You have to pull data if nothing was done for the past 3 years, and say what happened over the last 3 years with your implementation strategies. Were you able to work on everything that you said you were going to? What are the outcomes? What are the impacts from that? Are there things that didn't happen? Were there any stories? And by that I mean, we changed the time of year and location for the senior health fair, and we had 4 times the amount of seniors in the screenings that we did and the cancers that we caught, for instance. It was just, a really great thing that we changed that, but putting some of that information in so it's just not all numbers is important as well. Metrics and evaluation for your needs assessment. Implementation plan and prioritize strategies and metrics that show the progress and impact in the community. Who are you engaging in your metrics? Are you using logic models in order to think about alignment between strategies and metrics and how to capture that and making sure you're capturing everything? Is it okay to say, geez, this is our first year really making the needs assessment a top priority, and the implementation strategies were very ambitious. And when we took a step back and started to look at it, we couldn't implement A, B, and C, but we actually created protocols so that for year 2 we can start to actually collect the data. That's fine. Showing the community and showing the IRS that you're actually working on progressing that implementation strategy is what they're looking for. Monitor your team function and performance. That's why we suggest meeting quarterly, because you always have that one department that you just have to nag and nag to get the information. But if you brought them together for a 30-minute meeting by department to say, hey, what have you done? Or send me the stuff in advance and let's talk about it, really kind of gets them in the habit of saying, oh, our quarter's ended, I better get those numbers, to Susan. Check to ensure that the tracking and reporting systems are developed and implemented. Again, that's where an informatics person can help you with that. And at the end of the year, actually evaluate the process, create a report that can be then attached to the 990 and then saved so that when you have to do your next evaluation for your CHNA, you have all that information, and it's a quick way to create a report. Create a systematic approach. Oversee the development of an annual evaluation that we've talked about that can be reviewed by the board and included in the 990, and capture key processes. Develop an operations manual if need be, with a calendar of activities so that you know exactly what you did and how you can replicate that in 3 years. We also have a case study. One of our clients, Wellstar West Georgia Medical Center, they had one overall needs assessment for Wellstar, but that also included their Commission on Cancer CHNA that they had to do because they are a certified commission on cancer. And so by asking a couple additional questions on surveys and pulling in some additional cancer numbers, they were able to just do one needs assessment as opposed to 2 separate. And for their overall goal, so when we helped them create a logic model, we said, why are you doing what you're doing with the cancer program? Because they really are using patient navigators and tracking patients for their stress level and following them the entire way, to the point that their support group numbers have gone down because they have someone with them the entire time from the hospital. And they said, well, we want to reduce the stages 3 and 4 of cancer and, catch them in 0, 1, and 2. And so they really went on a campaign to make sure that happened. Criteria for a vendor selection, if you wanted to have a vendor assist you with it, would be, what is their approach, what is their experience, what is their knowledge, have they done them before, what is the cost, are you comfortable with them? Because, there are, clients that we have the first go around that said, we want to try this in-house. They started it and said, oh my gosh, we can't, and then called, or they said, you know what, can you just be available for questions, or can you come down and do our focus groups? So you want to, if you don't think you can do it yourself, is to look and see who you might be comfortable with, which is totally acceptable by the IRS. So in summary, and I apologize that we are a little over our hour, within your organization, you have an important role as the driver of your China's priority areas. The new thing is to, focus on social determinants of health and their influence on the health. Take the leadership role with your community. Use this as a stepping stone to create a collaboration or a consortium of all kinds of agencies in the area that might have a touch point on needs of the community, and work together to really move the needle over the next 3 years. Work collaboratively within your organization, within your region. If you really don't have a good relationship with the cardiac department, but that heart disease has gone up in your area, buy the person a cup of coffee, create, a relationship so that you can work collaboratively with them moving forward. Make sure that you include your public health department and community organizations once you identify the areas. Create your CHNA. It's a renewable cycle. It's every 3 years, but what can you do in between to make sure that the ball keeps rolling? And you want to advocate for the resources that you need to carry out your CHNA and beyond, which is why you need to really make sure that those senior leaders are part of your steering committee so that they get it, or talk to them prior to kicking off your needs assessment, saying, we really need to make sure that this just doesn't get put on a shelf, that we really are all in this together and understand the importance of it, and working toward the common goal is very important. I am going to send you some information. I'll send you the webinar recording. I'll send you the presentation, and I'll also send you some samples of what we have talked about, the Lehigh Valley implementation strategy sample, which shows that if you have a health system, showing how you can do the implementation strategy wording prior to the grid, particular to each location, but then having just one grid that is X'd by what hospital location is doing what. Also send you the logic model template, and then the sample information on the breast cancer program. So, does anybody have any questions? And Margaret, I'm sorry I talked fast. I was trying to get everything in, but I definitely will make everything available to everybody. So I will send that out in a couple hours after the recording gets uploaded. But anyone have any questions? Well, if not, I really thank you all for taking time out of your day to learn more about what's expected of you with your next go-around of your community health needs assessment, and I wish you all a great day.